Roll call.
Weiss,
Yes.
Rogers,
Yes.
Wade,
Yes.
Festerson,
Yes.
Wilkins,
Yes.
Espinoza.
The item of emergency is to add as letter I, opposition to Legislative Bill 421. In the legislature, that will be heard today, and we need to be on the record for it. So with that, is there a motion to add item I, LB 421, opposition to the agenda?
So moved.
Motion by Wilkins, is there a second?
Second?
Second by Weiss. Any questions? Roll call.
Wilkins,
Yes.
Rogers,
Yes.
Espinoza, Jones, Wade,
Yes.
Weiss,
Yes.
and Festerson.
Yes.
We'll now go to item 4. Items A through I are now on the agenda. I'd like to remove item E to vote separately. If nothing needs to be removed, I'd ask for a motion to approve items A through I minus E.
So moved.
Moved by Wilkins, there a second? Second by Wade. Any questions?
Let's have some discussion.
Please.
So back to item I that we added, since that's the matter with a bit of urgency today with a public hearing. I'm supportive of what the resolution does here. I just wanted to add a little discussion from the city's perspective in our analysis of this bill, LB 421. So our analysis is that should this bill pass, we don't think, the city doesn't think, it impacts the ordinance adopted by the city council, nor would it require us to change anything that was involved in that ordinance. Our ordinance, as you know, only applies to pandemic designated health measures and does not otherwise apply to items of concern in this resolution that talk about, day-to-day concerns of the Board of Public Health around, disease control and contagious diseases, tuberculosis, for example, and others. But should it pass, as you know, it's a complicated discussion as to the city's public health director, who is the county's public health director, and what those separation of powers would be. And then certainly it would negatively impact the Board of Public Health's ability to take such measures in the county outside of city limits. So it is quite a confusing bill, and I think it's an appropriate thing to be doing today to express the Board of Public Health's opposition to it in that respect. And then I was asking the chairman, since I'm new on the board here, I didn't know should this be adopted today, what does that then enact? I know the county, Douglas County, has a lobbying firm who actually happens to be the lobbying firm for the city too, but I don't know if this officially then enacts them to engage in this issue, or who might then convey this opposition if it's adopted today.
And to continue that discussion on the record, the conversation that Councilman Festerson and I had is that yes, Kelly Plucker could engage with this. They do the Board of Health lobbying, but traditionally the first swing at it has been through the Friends of Public Health, which will take the lead on it, and they will assist as needed. Any other?
This afternoon.
Yep.
Got it.
I know, Dr. Hughes, you want to note on the record who will be testifying in that respect?
Have to figure out which one works.
Should be a one to
Does
the.
that work?
Yeah.
Oh, look at that. Sure, I can do that. On behalf of Friends of Public Health, I know one health director from Kearney is planning to be there to testify, and that decision was come to after quite a bit of deliberation within Friends. And then there are a couple of physicians, one from Omaha, one from Lincoln, who will be testifying specifically. Those are infectious disease doctors. The one from Omaha is Dr. Lawler from UNMC. And I also am aware that there are some other organizations that do plan to testify, including the Nebraska Nurses Association.
Questions, concerns, comments? All right. With that, roll call.
Wilkins,
Yes.
Wade,
Yes.
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 We'll now move to item E, agreement with Charles Drew, Community Health Center for WIC. I asked for that to be removed so I can abstain because I sit on that board. Is there a motion to approve item E?
So moved.
Motion by Wilkins, a second.
Second?
Second by Weiss. Roll call.
Yes.
Yes.
Abstain.
Yes.
Go to item 5 and the Health Director's report and issue discussion. Dr. Hughes.
Good morning.
Morning.
So I don't have a lot to update you on in terms of the health department today because that personnel report is now in your written reports. So we don't have to cover that. However, we were going to talk a little bit about the COVID-19 dashboard, and I'm very excited to show you today the health dashboard that will be going live probably sometime today. So my chief of epidemiology has been working very closely with our GIS people who typically are the ones putting together that dashboard and updating and kind of changing the layout and things like that. And I am really excited about this. It really will become a one-stop shop for the community, not only for respiratory diseases, but for other things that are happening within the health department for which we have a dashboard. So it kind of pulls information all together, and I think that's going to be a great utility going forward. So I'm going to let Justin actually walk you through this quickly because he knows the layout, he knows kind of what GIS has decided to do. So Justin, if you want to come up.
Good morning. Everybody ready for the snow? You guys don't seem too excited. Let's see. I am going to share this screen. Okay. So, for the last 3 years, you guys are all very familiar with the COVID dashboard that we've been using. It's been a very important mechanism for communicating COVID activity in our community. But recently, this past year, a lot of those variables or kind of metrics that we have on that current dashboard are a little bit outdated. And we've been following this pandemic for 3 years, so a lot of our graphics are over a 3-year period, which makes it kind of difficult to compare and contrast between years. We also have a lot of maps and things on the old dashboard that we're using to track transmission within our community when COVID first began. This year, we had a quick increase in influenza that we hadn't seen in the past few years, and we had historic RSV numbers. So it kind of led us to start thinking about how can we better display this data for our community to better tell our story about what's happening with respiratory diseases. So we worked closely with GIS, and we came up with this health data portal, which is not quite ready. And we continue to work on the respiratory illness piece because we're removing some of those metrics, but we're adding others. So some that we might be adding would be like wastewater, which is becoming an important measure of COVID transmission in our community. It also took on a little more of its own life where the health department, we have lots of different, you can see each of these are called cards. So you can see restaurant ratings, air quality, animal permits, etc. So the health department collaborates a lot with GIS, but these sites were all over our website and not easy for the consumer or the public to find. And so we came up with this idea of putting them all on this kind of public health data portal. But the reason that I'm here today is to kind of give you a little preview of the COVID dashboard that we're currently working on. So this looks very familiar to the old one, but we are working on updating some of the colors and things. I was not much of a fan of the pastels. But you can see that we have 7-day total, but we've also started to include the percent increase from the previous week so that people can come onto the website and they can see that over the last 7 days, we've actually had an increase of 46% per 100,000. Same thing with percent positive. You can see that we had a 13% increase in things. So people can quickly see this at a glance and are able to tell, if we're moving in the wrong direction or the right direction, if you will. We, down at the bottom, this will be changed a little bit, but we had some requests from some of our public health academic partners to include the COVID-19 transmission level in addition to the COVID-19 community level, which I can explain if somebody wants, but the transmission level is really looking at the number of cases and percent positive, and that's used for healthcare to determine what preventative measures they need to take within their facilities to limit transmission. The other thing that I was talking a little bit about briefly is the fact that we've been following this pandemic for almost 3 years now. And on our previous dashboard, our actual graphics or epi curves, if you will, are over a 3-year period. We are now moving to, like any other disease, you can see that we have each year represented by a line here so that people can easily see where we are in comparison to previous years with COVID-19. So you can look at percent positive, you can look at emergency department visits, COVID tests performed, and positive tests. This is our demographics page, which is not done, but again, we'll probably be doing something very similar where we have the year, and if we're looking at age, we'll have different age groups by year on the x-axis so that, again, you can compare from year to year who's mostly being affected by the pandemic. And then deaths, and we're still working on this piece here. Hospitalization, we actually pulled out because I think it's really important. This past year, we had not only COVID, but we had what was kind of referred to as the tridemic. We had COVID, we had influenza, and we had RSV. So we had a lot of discussion around whether or not this is still applicable, but I think it is, and I hope that you do as well. With all of these respiratory illnesses, I think hospital capacity is extremely important for the public to understand, and hopefully drives home the message that everyone should be taking preventative measures, whether that's being boosted or receiving their annual influenza vaccine. And like I said, at the bottom, and this turned into more than I had thought, but I think it's turning out really, really nice. We have all of these additional cards for any of the GIS sites that we use for the health department, which I'm happy to go through, but I don't necessarily know that I need to. I know that was really short, but I wanted to give you an introduction to the new dashboard. We've been promising it. We've been working a lot on it, working with GIS and formalizing how we can best move forward. So if you have any questions, I'd be happy to answer them at this time. Yeah.
Not specific to the dashboard, but more of like, how are we informing the public once the federal emergency ends? Like, what's covered, what's not, where can you get a vaccine, that kind of thing? Or maybe Dr. Hughes is more appropriate for that question.
Perhaps.
We're actually having conversations internally now to determine the best way to make sure that we're communicating that information and making sure people understand kind of what that impact is actually going to look like, providing talking points to our information line, since that's a fairly popular way for people to get information. But we will be putting out more information shortly, really, regarding what that means. Does that mean you can't get vaccines anymore, since those were under an EUA? We know that will not end with the end of the emergency declaration. So yes, we will be kind of putting out a more comprehensive communication regarding that very soon.
So there will be no charge associated with the COVID vaccine. Is that your understanding? Because I heard differently.
Yeah, and there will be more information coming out, but I believe that is the case, that at least in public health, we're able to still offer that at no cost. There may be an administration fee at other places, which isn't charging for the vaccine itself. But yeah, we would plan to keep things pretty close to the same as much as possible.
Leah had raised her hand, maybe in response.
Do we have one online? Oh, that wasn't it. Who was it that had their hand up?
Oh, that was me. This is Leah. Hey, I was gonna say, at least for vaccine, I know that until the federal government runs out of what they've already purchased, we will still be offering for free. I can't guarantee the date on that or what that time frame looks like. They haven't really given us an idea yet, but at least for the upcoming months, it should be covered. I hope that kind of answers without, we just don't have any definite timeline on it.
Thank you, Leah. I feel like it's a good time to really make a final push for the public if they are, needing a booster or even starting the original series.
Yeah, we've been trying. Our numbers have just been super low.
Any other questions?
Thank you. Great. Thank you to Justin for that. And I'm just super excited to see how this has come together. And thank you very much for taking my vision and incorporating with yours and pushing it forward. I very much appreciate that. So I promised you a quick legislative update, and I apologize that you haven't had anything in your inbox yet on this. That will come before the end of the meeting today, but our finalized list from Friends of Public Health came out not long ago, so it was not ready at the time that we last met. So we're actually monitoring over 50 bills, and so I am certainly not going to go over 50 bills with you today. I would really like to just focus on just a very fast mention of the ones that we are supporting or opposing, and then if you have any further questions, we can go into that. So right now, LB 12 is a bill that was introduced by Senator Blood and would create the Nebraska Human Breast Milk Bank, and we are, again, sending a letter of support for that. LB 13 requires coverage of human breast milk under the Medical Assistance Act, also introduced by Senator Blood, and again, sending a letter of support for that. LB 62 was introduced by Kavanaugh and provides for coverage of translation and interpretation services under the Medical Assistance Program. We plan to also send a letter of support for that. That would, by the way, be great for Douglas County Health Department should we ever move to a fiscal model where we are able to recoup costs through insurance for interpretation services. All right. LB 114 was introduced by Vargas, and this is the state intending to appropriate funds to the Department of Health and Human Services for evidence-based early intervention home visitation programs, and we definitely do support that one and had planned to testify with that one. LB 115 was introduced by Raybold, and this is adopting the Family Home Visitation Act. Also support that and plan testimony on that. LB 145 was introduced by Bostar. Change provisions relating to coverage for screening, mammography, and breast examinations. We are planning to send a letter of support for that. LB 262 was introduced by the Ag Committee, and this is change and eliminate provisions of the Nebraska Pure Food Act. This is one that we have discussed internally at great length and plan to, we oppose that bill for sure and will testify on that as appropriate. Okay. LB 321, introduced by Brandt, is change provisions of the Nebraska Pure Food Act. Again, this is one that we plan to oppose and testify. LB 326 was introduced by Raybold, provide for eligibility for certain children under the Medical Assistance Act, and that is one that we plan to send a letter of support.
Was that 326 you said? Okay.
326. LB 358, state intent to increase dental services reimbursement under the Medical Assistance Act. We are planning to send a letter of support for that. Just of note, Douglas County Health Department does not operate a dental program or an oral program. It would not necessarily impact us directly, but we certainly would want to see that happen for our families in our community who are seeking dental services. LB 383, Bostar again, change provisions related to insurance coverage for screenings for colorectal cancer. That is one also that we will send a letter of support for. LB 419, Wishart requires submission of a Medicaid state plan amendment to extend postpartum coverage. We definitely support this, and we will be sending a letter of support for that. That was LB 419, and that would extend the amount of time that women can remain on Medicaid after giving birth. All right, LB 421, I think we covered that. We certainly are planning to oppose that one. All right, and I apologize, there's just 51 bills, it's a lot. LB 584, impose a tax on selling or dealing in electronic nicotine delivery systems. We support that and we'll send testimony for that. LB 740 was introduced by Vargas. This is change provisions of the Nebraska Pure Food Act. We support that and will testify as appropriate there. LB 779, Bostar. Limit the amount an insured pays for prescription insulin drugs. Definitely supporting that one and plan to send a letter of support there. And that is the end of the list of the ones that we are either directly supporting or opposing. The rest, there is, again, quite an extensive list, which you'll see. And we're just monitoring the progress on those. So the status on that, you know, in terms of what we do with that bill certainly could change depending on what happens as these go through committees and hearings. So I may have another update for you that will include some different bills next month. We'll see. Does anyone have any questions on any of those at this time?
I think all those positions make sense. My question is just more of a process one for the Board of Public Health. When they take positions, is it being reviewed by staff or board members, or is there a committee that kind of reviews all these things, or how does it work?
Typically what happens is I will work with Commissioner Rogers if I think that there's one that, you know, we are wanting to support or oppose. Typically our process is to be united through the Friends of Public Health. But certainly there are times when something might impact Douglas County more than others, and so we may act differently. So even if Friends of Public Health, let's say, is only monitoring, we may choose to send people to testify if it's something that will really impact us or that we feel strongly about. I typically will work with the board president to determine if this is something we should support or not support. If we feel strongly, we can develop a resolution or a letter of support or whatever it is, seek approval. We haven't done it very much since I've been here, so correct me,
Yeah,
Chris.
no, I would say, I would say if everybody wants to stay just attentive and bring some recommendations, because usually it was before COVID. I think Dr. Port, before she left, she was the president of the Friends of Public Health. So being in that role, it would be more staff-led and up to us. And it would be more, at the beginning of the year, the bills would be identified. She would ask, would the board want them to support it by personal testimony or by letter? The board would lay that out. Now after COVID, everything just went boom because it was nothing else but that. But I think if we want to talk about that process and have that would just be, you know, we could use the existing committee with the administrative committee, which has that, or you can set up a special committee. But just know that if we go that route, right after the new year, we're gonna be together real intimately for about 2 weeks. So
Yeah.
if you all think that through, and we can come back after the session and see how it operates.
Sure.
But, in the past too, there's never been any money. So, we were asking and seeing what's what. I guess the surprise is, of all the years, there was no appropriations asked for. But I don't know if and I'd be interested for that question to be asked, where they think this puts us in the long run with the appropriations stuff that was approved last year. Because I know it has a couple of years worth of tail on it where it comes in. And I don't know after that if the department wants to get an idea where that puts us and talk to the board about it. But I'm just curious, of all the years, there was no appropriations asked this year.
And there is actually LB 814, appropriate funds for expense of Nebraska state government for the biennium ending June 30th, 2025, and appropriate federal funds allocated to the state of Nebraska pursuant to the Federal American Rescue Plan Act of 2021. So I
So
don't
it's
know.
temporary, it's not any like the other years, it was
Right.
core general stuff.
Right. So that is, I think, the only appropriation related bill I saw in here.
Okay. So I'm assuming next year they're gonna try to pick it back up with the general.
Yeah.
fund side. Okay.
Yeah.
Okay. But yeah, I would, if anybody has ideas for the process.
And then I
Let's
typically
go.
take whatever that ends up being back to Friends of Public Health, and they, for instance, if there's a letter of support that we, choose to write, I would give that to Friends, and they would upload that for us, before the deadline. And if there's testimony, we coordinate with Friends to be there and kind of make sure our talking points are in line and all of those things. So I am honestly this legislative session a lot more involved than I was last legislative session, because things were a little messy here in Douglas County, and my attention really needed to be focused locally last year. So this year I'm lucky enough to get to be a lot more involved in the process. So I'm, to an extent, still feeling my way through it as well.
Thanks.
I have a-
Anybody else?
I have a question.
Go ahead.
Good morning.
Good morning, Dr. King.
I'm not sure in the list that you mentioned for LBs that you're supporting or not supporting, if there was one around safe needle exchange for hepatitis or other illnesses that is being supported.
The one that was very recently introduced, that's not on our bill list yet because it was introduced so late. So it hadn't, the list came out before that was introduced. So I do imagine that there will be a stance on that one, and I don't know yet what that will look like because we haven't had that discussion just yet. I would imagine this week. Typically, Friends meets on Friday mornings, so I would anticipate there will be more discussion on that on Friday.
Okay, great. If you just keep us in the loop, that'd be great.
Yeah, absolutely.
Thank you.
Dr. Hughes, could you provide a brief description of Friends of Public Health?
Absolutely.
For those who might not.
Absolutely. So Friends of Public Health is an arm of the Nebraska Association of Local Health Directors. It's kind of the lobbying arm, if you will, or the legislative policy arm. And this is really a place where all of the local health directors across Nebraska are able to come together, review all of the bills that are before legislature, and really hash out what we think a good strategy would be for supporting or monitoring. And it's really a way to ensure that all of us across the state are providing a united front of public health as much as we possibly can. There are occasionally times where there's a diversion, but typically, this is just a way to ensure that all of the public health directors are very much up to date on whatever's happening in the legislature, and have the opportunity to work with a lobbyist to make sure our concerns are heard, if that helps.
Anyone else?
Oh, great. See if I can pull it up here. Thank you, Leah. LB 570 has a hearing set for 2/23, and that one was, what did she say? 570. Okay, adopt the Overdose Fatality Review Teams Act. So that is the one that we introduced from Douglas County that would allow us to essentially stand up and run a overdose fatality review team, very similar to what we do with FEMUR, or the Fetal Infant Mortality Review team, which is these types of review teams is really an evidence-based model to get to the root of what's driving deaths related to whatever. So fetal and infant mortality, or in this case, overdose fatalities. So obviously we know that it's substance use that leads to that. However, there's something behind that substance use. So it could be chronic homelessness. It could be, chronic unemployment. It can be, a number of things that are kind of underlying. So really looking at what it boils down to is looking at the social determinants of health and looking at, okay, what's the common denominator, if there is one? Where is this happening? So is this all concentrated in a particular zip code? Is there a particular race that's impacted more heavily than another? And that really gives us a lot of very rich information to then go back and plan our interventions in a very targeted way, since we typically have pretty limited resources. And I will say that these review teams are multidisciplinary. This is not just a team that operates within the health department. This includes partners from across the community who are involved in this case, substance use disorder management or prevention. And so it's really a community approach to figuring out what's going on and plan a really cohesive approach to eliminating whatever those factors are. Yeah.
Seeing nothing here, nothing online, seeing nothing. Got anything else?
I have nothing else for you if
Okay.
no one has any more questions.
Right. Thanks, Dr. Hughes.
Thank you all.
With that, we'll move on to item number 6 and presentations. And we welcome back CHI for the Community Benefits Advocacy Report. Kelly.
All right, let's see. Are you gonna help us with that? All right.
Well, we get a little technical assistance. Thank you all so much for having us back. It is a pleasure to see so many of you in person again. It's been a long time. And also to be able to share some of our work that we are very excited about and seek your feedback and questions to make sure that we're partnering effectively. Okay, perfect. Thank you so much. So I am Kelly Nielsen. I am the Division Vice President of Strategy. Let's see. Just kidding. Google? There we go. Here, I'm going to keep chatting if you don't mind. Yep. Getting that going. Apparently I can't navigate and chat at the same time. So Kelly Nielsen, I'm the Division Vice President of Strategy and Healthy Communities for CHI Health. And I'm just going to do a brief introduction, hand it over to Ashley, and she can introduce herself as well. So we have a lot of content for you this morning. We weren't necessarily intending to share all of it with you. We'll see how our time goes. We want to make sure that we focus on current work. So what are we investing in from the needs assessments and the results of that process here recently, and then some of the other driving forces and how we're really changing how we practice within our healthcare system. Obviously, we'll touch on our community benefit financials, and then if time, it sounded like there was some interest around some of the work that we did specifically in response to the pandemic, which seems like it was a long time ago. It wasn't, but also, may want to share some of that story that I don't think we've had a chance to share yet. So that's our plan, and obviously, even though we prepared content, certainly please interrupt with questions and comments, and we want to make sure that this is a collaborative opportunity. So I'm going to turn it over to Ashley.
Thanks so much, Kelly. Good morning, everyone. I'm Ashley Carroll. I'm the Division Manager of Community Benefit and Advocacy for CHI Health. And I, too, wanted to express my gratitude to Douglas County Health Department and to the Board of Health for giving us this opportunity this morning. So I have the distinct pleasure, if my slides will advance.
I think it's just the PDF.
Just slide. I have the distinct pleasure to share with you how our Omaha Metro CHI Health hospitals are responding to priority community health needs that were elevated through our most recent community health needs assessment. I'm not going to go through this slide. You're welcome, because you all, the health departments, really ushered us through the community health needs assessment process. The salient point I want to make here is, each of the respective health systems that participate in this process together then develop 3-year implementation plans. Just so you get a sense of our timeline, we developed our joint implementation plan with each of our Omaha Metro hospitals, wherein each hospital has specific strategies that they are specifically leading, and then there are strategies and initiatives that we are driving at the health system or division level through our Healthy Communities team. We presented that plan to our division board of directors in July, which was approved. And that also coincides with the launch of these 3-year plans. So we're about halfway through year 1. All right, so like I said, you all are well aware of the data and the process of the community health needs assessment. However, I did want to ground us, right, in some key findings that we reflected on through this most recent process, which did reflect pandemic impact. And what we found largely was that the top health needs did not fundamentally change from the 3 years prior. However, the pandemic did exacerbate existing health needs, particularly in the area of behavioral health. And it's noteworthy that each of our hospitals across Nebraska and Southwest Iowa have prioritized behavioral health because it is such a resounding need in each of our communities that we've assessed. So too, did we see convergence and increased exacerbation of needs related to health-related social needs, so safe and affordable housing, healthy food access, and we know too that the economic disruptions caused by the pandemic were not felt or distributed equitably in our community. So with each successive cycle of the CHNA and the development of the implementation plans that result, we strive to focus on the areas where we can make the greatest potential impact based on our existing resources and expertise and the partnerships that we have already forged and those that we seek to in pursuit of the optimal impact or the greatest potential impact we can have in these plans. What I'm heartened to say, despite starting this slide with the same health needs continually surface each successive time, right? We could easily become cynical about that. But what I'm really heartened by is just the eagerness of stakeholders engaged in this process, including Douglas County Health Department and our other health system partners, to look at persistent, long-standing health issues in new and different ways. And I hope what you'll see in the reflection of our implementation plan is new partnerships approaching these health issues from a different angle and continuing to invest in programs and activities that have shown to be effective and require long-term investment. We want to focus on those drivers of poor health outcomes and on reducing health disparities to achieve health equity in our community. So based on the community's priority health needs, we have reprioritized for our Omaha Metro hospitals the following 3 focus areas, putting health equity at the center of everything that we do. So behavioral health, violence prevention and intervention, and health-related social needs. In developing our implementation plans, we conceptualized our involvement along a continuum. So there are hospital and clinic-based programs where we are driving that initiative. There are another host of strategies in which we are partnering with a community-based organization, and still other tactics and activities where we are investing in community capacity to address the health need. So with regard to behavioral health, we have several overarching strategies, including expanding access to mental health services in the appropriate care setting, including hospital, clinic, and community-based access points, expanding community capacity to reduce mental health stigma and foster resiliency, and you can see an example of that on the What Makes Us campaign led by the Wellbeing Partners, and recruiting and retaining a behavioral health workforce through educational partnerships and innovative care delivery models. Health-related social needs is a vast category, so how we're defining that is along these domains: healthy food access, housing and homelessness, resource navigation, and in particular, leveraging community health workers to bridge hospital and clinical care settings and community resource networks, as well as workforce development and economic self-sufficiency. So I'd like to take a moment and provide an example of an exemplary program we believe that's addressing health-related social needs. The Community Link program was established to help us move upstream in the healthcare continuum to identify our patients' health-related social needs and connect them to community resources to mitigate those social risk factors that impose barriers to optimal health, to managing a healthy lifestyle, and potentially managing a chronic health condition. Currently, we have 5 Community Link advocates who are akin to a community health worker. They receive referrals from all of our Omaha Metro primary care clinics, and they also have a physical presence in several of our Omaha Metro and Council Bluffs clinics. They receive referrals from all of those primary care sites. We're also leveraging...
Ashley, let me hold on. I just want to make sure I got that.
Yeah.
So I can follow in context.
Please.
You're calling your Community Link advocates. They're basically synonymous with your community
Correct.
health. Okay.
Yes,
all right.
that's just the terminology used in the program. Yeah, thank you for that question. This group is also on the leading edge of informing not only our Omaha market strategy, but a division strategy for integrating social needs into the healthcare delivery model. And some concrete examples of that are informing the development, refinement, and assessment of a universal health-related social needs screening protocol, which we just launched yesterday in our primary care clinics and women's health clinics. Additionally, they are our super users of the secure social needs referral platform, Unite Us, which we are hopeful will have positive impacts both at the patient level by connecting them into a constellation of community resources that often have a compounding effect. So if you think about the referral that goes to a food pantry to assist a patient in applying for SNAP benefits often has a compounding effect in that food pantry might also send additional referrals for that patient to acquire additional resources that they might need. We also think there could be some care team efficiencies, right? So now our Community Link advocates may not have to call 5 separate food pantries, but they can send a batch referral to provision quickly a resource for that patient. And then we also are hopeful about the opportunity at a community or macro level to identify community resource gaps and mobilize action through that aggregate data through the Unite Us platform. Another example of our health-related social needs work is the Pathways Community Hub pilot, of which I hope some of you are at least a little bit familiar. This is an evidence-based model that leverages community health workers to reduce social risk factors for poor health outcomes. The model has been evaluated and shown to be effective in a variety of health issues and patient contexts. Our initial pilot is going to focus on improving birth outcomes and reducing racial and ethnic disparities therein, particularly focused in East Douglas County, where we know the greatest burden of infant mortality is experienced, particularly among pregnant and birthing people who identify as Black or African American. And so some of the next steps related to the Pathways Community Hub include hiring a Pathways Community Hub director, recruiting and training community health workers. These are folks who are already doing this work in the community, but training them on use of a standard risk assessment and care management protocol, documentation, and billing process so that we can sustainably finance community health workers who are so often grant funded, and so the sustainability of their positions is often in peril, though we know they are such a critical care team member. Another example of burgeoning work with regard to health-related social needs is our programs related to housing stability. And there's really two veins here that I want to highlight for you, which is our partnership with Together Inc. to provide inpatient case management to our patients at CUMC Bergen Mercy who might have barriers to safely discharging beyond the time that acute care is no longer needed. So a case manager can come and help them, either work with a landlord or get them on a housing waiting list so that they do have a safe and supportive environment where they can safely recover. And that is bearing wonderful outcomes and results that we would love to share if time was permitting at a later time. Another important vein of this work, too, is the establishment of the Health and Housing Coalition, which is comprised of the major health systems in the area, shelter providers, our federally qualified health centers, the health departments, and many others, which has already borne fruit in one of our earliest successes being the development and launch of a community medical respite pilot led by Charles Drew and Sienna Francis. Our third and final focus area is on violence prevention and intervention, and our two objectives therein are increasing our health system capacity to identify victims of intimate partner violence, human trafficking, and sexual assault, and provide trauma-informed care to those patients. The second objective is to increase community capacity to do that very same thing. So the images you see on the right are of the Regional Anti-Trafficking Conference that we most recently hosted that brought together interdisciplinary stakeholders, health professionals, law enforcement, social service agencies, and others. And the other image is of the human trafficking training that we developed in partnership with UNMC and WCA, designed for cosmetologists and individuals in the personal care industry. Now, the next three slides I'm going to just cycle through. I provided these for your benefit and perusal at a later time. Of course, time permitting and attention limiting, I didn't want to go through each of the strategies, but wanted you to have those for reference. I'm sorry.
She said, can you roll back?
She wanted to see
The partners, yeah.
Oh, yes, that is upcoming. So, and momentarily, I'll show you the community partner slide here in just one moment. And momentarily, I'm going to turn it over to Kelly, and she's going to provide an overview of our community benefit financial impact. But I thought it was noteworthy that we define our role in terms of community benefit in a variety of ways. And one of the ways that the Healthy Communities team helps to extend our reach and increase our impact is through the provision of additional grant dollars that help us catalyze new programs and often help our community partners leverage that as match dollars to secure additional funding for their successful programs. So we have secured in recent years through multi-year awards $2.8 million that is not reflected in our community benefit financials, but we believe is core to living out our mission and part of our role as an anchor institution. Here is not a comprehensive listing of the community partners that we are currently engaging with on this ambitious plan. We recognize that it takes an all-hands-on approach to making meaningful impact in these health need areas, and we are super grateful for the folks and for this list that continues to grow. From the last time we were here a few years ago, there are many new faces on this list, and so we're in deep gratitude for those who are willing to roll their sleeves up with us. With that, I'm going to turn it over.
Did you have a question specifically on the partners?
I was actually more curious about the partners involved in the joint initiatives that was those slides before.
So, like medical respite?
Yes.
Unite Us.
You
Yeah.
mentioned there were other health systems.
So in many examples, for example, the Health and Housing Coalition, one more, or this slide? No? This one? This one. Yeah, there we go. So the partners under the Omaha Metro Joint Plan heading are our hospitals who are partnering in this joint plan, right? So They all have participated in the community health needs assessment process together, have all prioritized these 3 health need areas: behavioral health, health-related social needs, and violence prevention and intervention. Those certain hospitals are best positioned to lead a respective strategy. Does that answer your question?
Yes, that helps clarify. Did you mention at the beginning something about, like, you as CHI have your own, but then with other health systems, you were working on some joint initiatives?
Yeah, we're super fortunate. You know, all not-for-profit hospitals are required to complete a community health needs assessment and develop an implementation plan. Our Midwest division, right, encompasses 4 states, and I can tell you that the Omaha Metro is quite unique in our collaborative approach. So the CHNA is conducted with investment and partnership from each of our major health systems. And then we also develop plans in a very transparent and collaborative process, because it doesn't make any sense for us to be developing strategies in silos and you know, without recognition of what's already working well in the community that we can help scale and partner on. So that is our approach, and we're really grateful for our other health systems who share that philosophy with us.
I'm going to add to that. I remember, this is at least my 3rd round of community health needs assessments with the health systems, and I remember my first meeting, however many years ago that was, and in planning the needs assessment, and there was a counterpart at one of the other hospitals that said, well, we're not going to collaborate on implementation plans, we're competitors. And I remember trying to hold my jaw, right, from dropping, and it was like, what did I just get myself into, right? And what was really great, at least at that point, is we were able to at least start to reframe the conversation a little bit in saying, well, maybe we're not going to, you know, collaborate on cancer services, which I still don't necessarily agree on, but let's talk about violence prevention, right? What are the spaces where we aren't in competition and we really need to think differently? And I would say in those last now 7, 8, 9 years, however long it's been, that we have seen significant development in how we come together and partner, not just on the needs assessment, but starting to develop those implementation strategies. I would argue we still have a long way to go, but there are some really good examples here where at least we're convening in different spaces. The mental health stigma work was one of the first spaces where really all the health partners said, we're going to put our work behind one issue and rally around that. The health systems all still developed our own plans in addition to that, but we at least had that one shared effort. Other ways that has evolved, the medical respite initiative that Ashley spoke to briefly, which is out of the Health and Housing Coalition. So all of the hospital partners are at the table, as well as all the shelter partners and some of the actual Medicaid managed organizations. That's actually been an emerging partner for us in the last several years, is the MCOs. That have directly resulted in the Pathways Hub Institute, for example, being able to put that in place with funding from Common Spirit Health, our national organization, and all of the MCOs. That's the first time that we're aware of folks actually co-funding something like that. And while the other health systems have been at the table in some of the planning, we're still working towards further integration of their priorities within that work. There's a couple other examples of that, and I'm glad that Ashley called out that Unite Us example, because that was something I wanted to connect actually to even the presentation shared earlier around the dashboard, right? Is we have this opportunity now to collect data that hasn't existed on the social needs of individuals from all of the health systems and community partners, and that is leveraged through Sync Health. And so that can also, as Ashley mentioned, help us understand at a broader scale what is going on with individuals in our community. That can inform our needs assessment, that can inform some of these health issues like housing that we all need to solve together, right? Like, it's not our role to say CHI Health is coming in and solving the housing problem. First of all, that's ridiculous. We can't do it. But it's also something that we're all jointly wrestling with to make sure we can provide those services to individuals and really change the system. So I think we've made incredible progress, and there's some really tangible examples of that collaboration, and I think, I hope, a lot more opportunity to evolve that. So hopefully that
I have a question.
further.
I have a question.
Yeah.
For the Unite Us platform, are there challenges with that in terms of, my understanding is that community partners or organizations can have the choice to opt in, and if they choose not to opt in, then that's kind of missing data for the health systems. Have you run into those challenges? And if so, like, kind of how have you mitigated them?
Yeah, certainly. We are grateful for United Way of the Midlands and 211 for stepping up as we reach critical mass for community partners joining the platform, and frankly health systems, right? It was kind of a chicken or the egg. Like, neither was super incentivized to join the network unless their referral partners were actively on there. And so 211 really stepped up and provided a dedicated central navigation function so that our clinical care team members, again, largely our users at this time are our community link advocates and our social workers. They didn't need to make that determination of whether or not a community resource or a community-based organization was active on the platform. Because 211 Central Navigation Service existed and was active on the platform, they could simply be focused on provision of that resource for their patient, and then 211 would pick up that referral and directly call that agency and say, hey, just wanted you to know, had you been on the platform, you would have received this referral electronically, but I'm making this phone call to you to let you know that you have a referral from CHI Health, for example. We recognize and can appreciate yet another technology and another system that already really lean nonprofits have to use, right? And so those challenges, I think, are real and something that we will continually evaluate. But I think there is tremendous value in a single solution, to Kelly's point, right? So that we can, in aggregate, see where, what are those health issues that we are commonly, not simply our system, but all of our health systems and all of our agencies are referring our patients for, and also importantly, what are those health needs or services that are commonly unresolved because services don't exist in sufficient quantity to meet community demand.
And hopefully we can better build that case as some organizations come on and we can show the value add, how it did help their teams, how the data can help inform their work. So it's hopefully someday not just an extra thing, right? I know that we have taken a lot of time, so I want to keep going, or maybe...
We planned accordingly, so you got a little more time. But let me ask you, because I got a slew of questions for you, but I want to follow up on Dr. King's. So you're saying 211 is kind of so you got Unite Us.
Mm-hmm.
Your community health workers are putting information in Unite Us. I know there's another group at Creighton that's using Unite Us for the Medicaid.
The Creighton Community Collaborative.
Yes.
Yeah.
But 211 is kind of this behind the scenes facilitator. They're taking some route in. So whatever information 211 already gets in that deal, right, they're the behind the scenes soft handoff on some of this, and the stick they're using is encouraging people that you'd get a better full-throated, holistic view of what's available to you if you get in, and you wouldn't be out there on your own. That's the incentive stick. Okay.
Yeah, they're the critical success factor, right? If we were not able to access 211's service directory, that would be a steeper hill for us to climb in adopting use of this new technology. But they integrated their active resource directory, so the thousands of community-based organizations that one can access by calling 211 are now available through Unite Us.
Mm-hmm. Okay.
Can you kind of briefly describe this primary care referral process that was launched yesterday?
It's a screening protocol. So it has not been a uniform or universal practice to date to screen all patients for health-related social needs on a determined frequency. And so we have reviewed the literature, consulted with partners, including those through the Unite Us platform. So other health systems nationally are all sort of working hand in hand, because this is, emerging work. To look at what are the most effective screening tools for positively and reliably identifying patients' health-related social needs. And so we have worked with our electronic health vendor, Epic, to create a screening tool within the EHR so that all of our primary care patients on an annual frequency will be screened. It's a comprehensive 27-question set for health-related social needs, both primary care and then also women's health, because we understand that that's also a primary care source for many of our patients. And then we're also developing a more frequent, a shorter screening protocol that just encompasses 4 questions that will be rolled out at every provider visit in primary care and women's health, so that eventually becomes the standard of care, and patients expect that they're going to be asked every time they come in about any challenges in affording their medication, any challenges they have in making their mortgage or rent payments, and if they want any assistance with that, for example.
Okay.
Yeah, thank you for that question.
Okay, let me, Kelly, with you all, and this is county staff too, because I want to. So we had it out in we had the community health needs assessment out in the field, and it was out in the field questioning in 2021.
Mm-hmm.
That's the last time, and we're preparing now to do it to put it in the field in 24. So it was in the field in 21, completed, and this is where I want to just make sure I get, because the system came last week and taught that. So usually that's complete in 21. You all got your board's approval on these July, you said, of 2022.
The plans, the needs assessment was April of 22.
April of 22 done. You got the approval in June. So really, the practical operational 3-year cycle that you're operating on is 22 to 23, 24, 25. Because by the time 4 gets done and approved, it'll be ready to go. Okay.
Yep.
So these will operate till 25. Okay. This is a merge of questions that we had presented 2 months ago in here, but the question I had to bring up, Patty brought up, is there, because you got these community health workers, we got these community health workers. Is there a county, did she say there was a countywide effort somewhere where these community health workers get in the room? Because this is my connection. They have Intel. We have Intel. Now you got Sync Health. And so Sync Health is, I'm assuming Sync Health is playing this, at least from what I know of them and have been able to learn. Sync Health is playing this convener of the data to spit it out practically. So I guess my wonder is, with your community health workers, all these community health workers out here, who is gathering that qualitative stuff to make it quantitative and just help us see further out? Because all of them have this information. I'm like, okay, I want to understand this, to understand more color on this housing data, more color on all these other social needs. So that's not so much a question about you, but you raised it because you're in it. And I guess that's my question to somebody. Is there a gathering of these community health workers where we're gathering this intel?
Sorry about that. We have talked about that a number of times. And I don't believe that there is a formal structure for that yet, but that is definitely something, at least on the health department side, we have talked about at length, to, you know, really bring everybody into the room to ensure that we're not duplicating services, ensuring that we are filling gaps appropriately. I'm actually asking Leah for if she knows of anything, but to my knowledge, nothing formal has yet been stood up. For a while there, everyone was kind of setting up their CHW programs kind of at different times, you know, through their own strategies. So I think the work was new enough that that just hadn't been done yet.
There was convening pre-COVID, and headed in this direction, and you know, pandemic fell in the middle of things.
Okay,
But I would say that there's definitely, to Dr. Hughes' point, there's definitely a renewed energy and investment in this workforce, and that's part of the excitement around the Pathways Community Hub, is taking the model one step further and really putting in that financial sustainability. Fortunately, it's been proven in other communities, so we're very optimistic about success here, but obviously it's not in place yet. That would not solve for everything that you just mentioned. We would still, there's definitely still a value and a need to create a more comprehensive understanding of not just the workforce and how we're supporting that, but also how we are integrating and gathering that data and using it effectively. So absolutely a need.
So, let me pose this other question, because I'm gonna say to you all, over the years, at least from the first time we did this, I love the way you all have adjusted to it, and I'm gonna just say, and this is a message to the other systems too, but you all have, I felt of anybody, at least made me feel like you are taking at times I feel like sometimes the system will use community benefit to heighten an internal program, and it technically meets the law. But you all have continued to evolve, and I feel like you're leveraging it for a greater piece that meets your own personal needs, but also the community's piece. But I ask that like to say, pretty much the community health needs assessment doesn't give us, do you all think it gives us enough fluidness? Because basically once we do the survey, it's a set in time, and then stuff is development. And I mean that because we were in this session yesterday Sunday in DC. And I'm wondering, when you say behavioral health, you noted some things, but does behavioral health, is it broad enough and fluid enough to incorporate like this recent CDC report that talks about youth mental health and all of that? Do you think it's fluid enough to allow us to incorporate that in there? Because this was done in 2021, sorry. And all this stuff has developed after the pandemic, that everybody's saying youth suicide numbers are up. All this stuff is being tied to the pandemic. I guess the question is, in general, do we need to be thinking about a way, you have the set piece, but a way to engage locally some more fluidity in this as it evolves? Do you get my question?
I can start and have Ashley add in. So, I guess we think a little bit differently between needs assessments and implementation plans. So the needs assessment is a point in time.
Yeah.
It's a good time to level set, see how are we doing as a community, what do we prioritize. And then we have always developed and treated our plans as the best laid plans, and things change. And so I would say, if you look at what we put on paper and is approved by a board, and 3 years later, the work definitely evolves, and especially in the last 3 years, definitely should be responsive to community needs. Some things are really great ideas and they don't come to fruition for various reasons. Things emerge that we need to shift to. I would say that's a big challenge as well, because of capacity, right? There's always more need than we can address. And so it is also that it's really valuable for us to make sure that we have strong convening in the community to say, here's what the data is telling us, here's what the emerging opportunities are, here's a new initiative, how can the health systems participate and adjust? We get a lot thrown at us, and we want to make sure that we're prioritizing and investing in the right ways, and so we need support and partnership in doing that. But we certainly have no intention of what is on paper is all we're going to be focusing on. Does it mean if something comes up that we need to say, okay, well, let's focus on that and move away from this other thing? That may be true, because we just can't do it all. Yeah. But we definitely do want it to be fluid, but we do need that partnership and influence to say, like, here is where we really need the health systems to be engaged. So hopefully that helps address, and I don't know if you would add it.
Thanks, Kelly. I would add to that, again, the health systems and the health departments in the region collaborate through professional research consultants to conduct primary and secondary data collection and analysis. But we also take additional information into account in the development of our implementation plans. And so I think that kind of gets to that fluidity too. We recognize that we want to look at what are the pain points that our patients are experiencing, because our hospitals are a microcosm of the community that we serve too. So we're looking at hospital and clinic data, though you don't find that in the PRC report, right, at the community level. It's always a challenge, right? Because it is a point in time. It feels like, gosh, we just completed the CHNA and now we're gearing up to go in the field and do it again. At the same time, on the other end, you want real-time data, right? Because you're always looking in retrospect. I hope, have learned through the pandemic that we've got to be flexible, that there are always new and different ways and arguably better ways of completing this process and gathering quality actionable data in different ways and adding additional data points to our analysis. And so we are looking to the next CHNA with that perspective, is how can we do this more effectively? The community health survey is over 100 questions, right? That's pretty substantial and quite a tall order to ask of our residents. So can we leverage data from multiple systems to get a good understanding of what the top health needs are, at the same time reducing the burden of residents to complete a 100+ question survey set? Those are all the questions I think that each of the partners involved in this process consider when we begin to plan for the next CHNA.
So, I guess just for the sake of time, this is to the conversation that we had about the community health workers deal. So, you all seem like you're open to. I feel like it's the health department should probably take some lead in trying to convene these community health workers together to get this data. So, at least I'm saying, and the board needs to chime in. This is my field. I feel like we need to move now on that.
Yes.
So while you've been talking, I've been talking to Leah.
Okay.
To find out kind of, you had mentioned that prior to the pandemic, there had been some collaboration. It sounds like Carrie Kernan was the one who was actually spearheading that going forward. So Leah will take it going forward. So I would expect some emails shortly to plan some convening of systems who have community health workers. So
Awesome.
everyone can be on the same page.
Well, let me, and this is my rationale. This is the lack, because we can't get it all, but. And all of this is a napkin mindset right now, because it's literally was talked about Sunday at a table in Washington, D.C. But Friday, I'm sure some of you all, I don't know if you all met, you familiar with U-Turn?
Mm-hmm. Yeah.
And I guess they went from ceasefire, their U-Turn, then they brought a group called Cure Violence in here last week, and they were going around. And basically, Cure Violence has evolved to basically U-Turn's people are going to become community health workers, basically.
Yep. Yeah.
And then we had this conversation about we probably need to be putting our community health workers through that violence prevention model, and they need to be getting embraced over here through that. And I feel like there's this amount of data, this thing we're missing that we need to take advantage of, because all this discussion happening around here is got social determinants of health underpinning. All the violence prevention stuff is the housing underpinning, the food underpinning, and everybody probably needs to be getting in the room of how we use this data in a better way, be able to tell the story in a better way, and make the resource work together before all this ARPA money leaves, and we need to have a better system to make it go. And so if this is the feel I'm getting, I think that is something we need to get on immediately to use that, and then use this epidemiologist that's going to come in here on the 21st to be able to make this stuff work.
Yeah, can I add to that, Chris?
Go ahead.
So I brought this up at the December Board of Health meeting, that there should be some type of convening of all of the community health workers, and that it's happening at the national level with the National Association of Community Health Workers. So maybe that's our opportunity here to develop some type of local chapter so we can tap into there, not only for the national, but also for us to have a good reason to be here collaborating and sharing and integrating that data. So I would like to also reiterate that in this Board of Health meeting that we move on it right away, just as Chris mentioned.
I think it's very timely too, given that both Creighton and UNMC Center for Reducing Health Disparities recently received HRSA funding to develop CHW training and certification programs.
Absolutely.
Yeah.
Do we have maybe 3 minutes that I can just get a couple more talking points out? on other topics. Is that okay?
Yeah.
All right. So I really wanted to touch on a few things that are happening within the health system. So obviously the needs assessment is a driver of our work, as is our mission. But there's some really exciting evolution within healthcare that's really, I feel like, leapfrogging us ahead in how we think about these needs and address the needs of residents and patients. So one is the new Joint Commission accreditation standards. So as of January, so last month, there's a whole new set of requirements for Joint Commission accredited hospitals to be really thinking, yes, about addressing patient and individual patients' needs, but also really thinking about healthcare disparities. And so that involves identifying a leader at every hospital that's in charge of this, making sure that we're doing the screening every time someone's admitted. So Ashley spoke to the ambulatory side of screening and what we're putting in place within our clinics. This is hospital focused. So now upon admission, requirements around screening for social needs and providing resources. So it's not just screening, we're making sure that we're helping a patient. Then we also have to stratify our data across demographics to see what types of disparities and outcomes we're seeing amongst our own patient population. We have to set a priority, develop an action plan, report on progress on the action plan, and report publicly. So really, again, really exciting changes that are holding us accountable in a different way, even though this work was emerging. It's really expediting how we think about this within the hospital setting. And then if you go to the next slide, very similar, slightly different, of course, CMS standards, because why would they give us the same standards across agencies? But again, making sure that this is a strategic priority, so you can see the numbers of ways that we have to integrate this within our strategic plan, develop goals and actions, communicate it, stratify our data. We've always collected demographic data, but making sure that we're doing that with integrity and accuracy, that we have quality improvement processes in place, and that, again, we are communicating this work. Also includes a performance dashboard. So I feel like this component of the CMS standards actually really elevates both the integrity of the work as well as the accountability to the work. So that's a huge important piece. And so I wanted you to all understand that beyond community health needs assessments, beyond community benefit, there's a lot of really important related work happening within the health systems. And then just an FYI around requirements for screening. So CMS does require certain domains to be screened for. So talk about data, another piece of information that we'll need to think through if and how and when this is shared, because this should help us better capture what our needs are at a more global perspective. So that's work we're very thick in the middle of putting in place. Again, it was headed that direction, but this really puts some accountability and expedites the timeline. I was going to stop for questions, but I'm going to keep going, and then we'll stop. Just wanted to touch a few things on our community benefit results. So on the next slide, you do see that in FY22, we did contribute $118 million in community benefit. This is specifically in Omaha, so the 4 hospitals in Omaha. And what I wanted to call out is you'll see in general, this tends to be the same proportion of spend across those that are receiving financial assistance from us, the unpaid cost of serving those with Medicaid, sorry, the text is cut off there, and then our broader community health. We are seeing, actually, you know what, let's go to the next slide, because I think you can see those trends a little bit better. So we are seeing growth overall in our community benefit across years, and in both categories. And so what you see is about really broader community, I guess, is probably about the same, but we saw about a 20% growth from fiscal year 20 to fiscal year 22 in our contributions to the underinsured and uninsured in the service, the cost of providing that care. And actually, if you just want to go to the next slide, this is a lot of detail. I'm not going to go through it, but it breaks it down in the different categories in a way that helps you kind of see some of those trends. I know that we've talked over the years about potential impact of Medicaid on these numbers, and we really do see that. So with financial assistance, the timelines are switched on this one, so it's a little bit confusing. But on the left side, you see FY22, so that's the most recent fiscal year, and on the right side is fiscal year 20. And what you do see is over that 3-year period, we saw a 39% reduction in the financial assistance that we provided, but an 82% increase in the unpaid cost of Medicaid. We also see the numbers of persons served decreasing within financial assistance and increasing within Medicaid. So not only are we seeing a reversal of those numbers, but that population served with Medicaid is actually growing substantially within those that we're serving. Other than that, there's some ins and outs across broader community that is probably more detail than you need. But the bottom line is our contributions are growing. Ashley mentioned the needs are growing. I think that's partly reflected of that, as well as just an ongoing commitment to our mission. So just wanted a chance to call those out. I'm sure there's questions, but I'm not sure how much time we have. Yeah. Oh.
They just made a point about the Nebraska Commission on Housing and Homeless would be a good committee to work with on community health work services. So.
Great, excellent.
I just have a quick question. On that last slide, it said something about community building activities, and it went down over the years. What is that? Can you just define what that is?
I have notes, yeah.
Okay.
Yeah, there's very specific definitions of what the IRS counts as community investment and community building. In particular, what we've seen in that area is there's been some decrease in the tobacco education work coming out of Midlands Hospital. I think some of that's related to grant funding and then changes in staff and then implications of that. And I don't recall, do you remember off the top of your head the different definitions between community building and community investment?
No, I mean, like direct investment, so a grant that we provide to a community-based organization is likely to fall in that financial and in-kind contributions. So it's just some nuance between the different categories. But yeah, when we asked our financial analyst, why did this go down? They said the largest driver was specifically at Midlands Hospital related to this specific program that also leverages other funding. So we didn't have to provide as much financial contribution to that particular program.
Can you send your slides to the board?
Yes.
Thank you.
We would be happy to. Yep, they have them.
Okay. I want to thank you all again. I note this as I appreciate how you all have evolved over this, because I understand a little better than what I thought I did, but I do see the intention, at least from my view, and yes, you have to look out for the system to some degree, but it is the impact is a broader piece. And I just say for the record, the purpose of this is to just try to bring this out and educate people on it. But to your point, Kelly, it's hopefully to mitigate, the statements that's like made in the room, because even if, I understand the distinction between the nonprofit category and how it truly operates, but the common ground should come under the underpinning that causes the result of the cancer, and we all should be able to get together on that. So I thank you all again. Appreciate the time.
Thank you so much.
Thank you.
With that, there's the reports. The board has had those. Are there any questions any board members want to ask of the divisions regarding the reports?
I just had one.
Please.
I had one question. I had seen that within the WIC program, the allowance to use different brands for formula was going away this month. And so just getting clarity that the formula shortages that have been occurring, has that resolved? Are the WIC approved brands now fully stocked?
Yes, they are fully stocked.
Okay, good. I just didn't want to verify that we weren't going to cause families to not have access to
Yeah, we made sure of that and wanted to, before putting that information out there, but yes. So,
Okay.
And if for some reason there is an issue, there are waivers that can occur for that we can work with other brands if need be.
Thank you.
I had a question. I didn't see a whole lot about the community health workers and some of the questions that I posed back in December related to kind of the survey and what we were doing to have more alignment amongst the community health workers. So I was just curious where that is and if there's an update on it or if there's any work that's been done since then.
Can you remind me of your specific questions again, Dr. King?
There was a survey that Tia did, and she was administering that.
Okay.
And I didn't know whether the other community health workers were also going to jump on with that administration or figuring out how do we better refine that survey so it's validated rather than it just being homegrown.
So I have a student that's been working with us to kind of analyze that data, and that's what we've been waiting for because our community health workers aren't on the analysis data side. So having to have someone kind of look into that, we were waiting to bring him on. He was helping with that. So I should have some info soon on the feedback from that. And then we're also hoping to hear some more information about a electronic version that I've been working with UNO staff, faculty over there on a misinformation surveillance system sort of thing. So we're hoping to utilize that in order to have a more mobile version of it. So as soon as I do have info, I'm happy to share that.
Awesome. Would you happen to have those analyses done by our next Board of Health meeting?
I can sure see.
Awesome, thank you.
And I'll just note really quick, Dr. King, that I do believe that when the community health workers came last to speak, we decided that Patty Falcone would come again in March to do an update, so she is on the agenda for next month.
Great.
I don't know if she knows that. I guess she does now. But she did talk about it, and she's pretty good at details, so I would think she remembered that. But yeah, she should be coming back to talk more.
Great. And then just curious if the Division of Health Equity is involved with any of the community health worker work that's happening. It makes sense for that, considering health equity is a part of the work that community health workers do. So just trying to see if there's some cross collaboration amongst those divisions and other divisions, really, because when I read the reports, there's opportunities, I think, with the divisions to do more collaborations rather than working in silos. And I don't know, I can't tell from a report if there's actually that going on. So I think it would be nice to start having some presentations again from each of the divisions, but that's just me.
We can certainly look at that. With our limited time, it's a little difficult to work in too many presentations, but I will definitely keep that in mind for the agenda. Does our new division chief want to say anything about involvement from that division in this work, since he's in the room?
While he's coming up, I want to remind us that we did do division presentations prior to COVID, and the only reason we switched was because of COVID. So I think it would be beneficial that we get back to that.
Well, before you go, Jamie, let me know, one of the kind of trade-offs to get back in the big room is because of room constraints. We got a little leeway, but I told them I'd start is we're gonna have a hard 10 o'clock stop. So the board needs to consider either we want to go back to 8 o'clock instead of 8:30, or we'll probably have to evolve a little bit in more of the committee work. So you can, I would think some of those division presentations may be dug into a little bit more in committee, but because of the room space, I told them we'd work on that hard 10 o'clock in, so we can work through trying to add a couple of reports, but based on you all's request to want to start at 8:30, we can move it up a half hour and get it in, or we have to make the committee work. The committees work a little different.
Is there a way that they can just like record a 1 to 2 minute summary? Because it is hard to really get a good feel of what's going on within these division reports.
That's fine. I think if you all, I think the division reports are a work in progress. If you got some specific stuff you want to include in there, I think that's open. Yep.
Yeah, appreciate the feedback, and we can certainly dig into that a little bit.
Jamin, real quick.
Okay, I'll be fast. Thank you, members of the board. So to answer the question around collaboration between the Division of Equity and Planning and the work of our community health workers, I will say that Ms. Tia and the survey that she puts together. First, I want to applaud her for taking the initiative to recognize that there were questions that needed to be answered and work to identify what those answers were and how we can use that to drive the way that we're working to meet identified needs. I will also say that I've had an opportunity to sit down with her and to look at the survey, to talk through some of the opportunities to use some of our, we've just brought on a new qualitative data software that is going to help us be able to do some thematic clustering and be able to draw out a better it's a tool to help us draw out more data in the qualitative way, so that we can tell a more robust narrative as to impact and reach. So this is an area where I think the initial survey findings, along with the support and help from Justin and his team, we can probably plug that into our new software as sort of a way of training ourselves on how to use it. And then be able to look at what validated questions exist that get to the same questions that we're being asked, so that maybe we can create a holistic survey tool that can be used by all of our community health workers. But I think that, I just would be remiss without applauding the initiative of our community health workers and finding ways to be innovative and get answers to questions that are being posed to them or that they're identifying as experts within our community, and bringing them back to us so that we can be nimble and able to respond.
Look, I'd ask this to the board, if the board's interested in putting some more uniformity to the reports, that will probably make it a little easier for everybody. So you got some stuff, send it. Or if, there's some people that is interested, we can get together real quick here, like on a Zoom for an hour or so and talk through the report, see what it is, and get some standardized where everybody wants to be able to get in, and go from there. But there's no pride of ownership in the report format.
Yes, I do support Dr. King with that. I feel like now that we've cut a little bit of the time that we're reporting less with our COVID reports, and we have the room here available, maybe we can look into getting into an agenda of dividing the divisions and the departments, assigning them maybe a month so they can have enough time to present their information and gather their information, and maybe we can assign them to an agenda monthly and divide them by different departments. But I would see the benefit of having them here on person, or maybe having a video like Dr. King mentioned ahead of the time, because we are receiving the reports maybe 2 days before our meeting, and there's a lot of information compacted in those documents that I feel that I don't necessarily have the time to review every report. So I do support that. Maybe we can get back to that agenda, whether we're doing it in person or even just a small video presentation.
Okay, we'll see. All righty. Any other questions, division questions? All righty, then next board meeting is March 15th here. I'm assuming by the board's response, they don't want to adjust the meetings back to 8, they're fine with 8:30, and we'll just make it according.
I just want to be clear that the reason that I asked for it to be later is because OPS does not allow you to drop your kids off earlier than 8:30.
No, I respect that.
I
I've been
mean,
there.
it's
I
not that
understand.
I can't go back to 8 because I'm the one that has to take my kid to school every day. I don't have a partner to help me do that. So that's the reason I asked.
No.
And I'm with Dr. King on that. We initially asked for 9 o'clock. So, I mean, if that's not doable, totally get it. But I think there's ways to accommodate it too.
No, I just want to make sure that everybody's on the same page. All right. Is there a motion to, you got a question? No. Is there a motion to adjourn? Motion to adjourn. Motion by Festus, is there a second?
Second.
Second by Wilkin. Roll call. Yes.
Yes.
Alrighty. See you all next month.